Deep tendon reflex is one of the most common component of motor system examination in a patient with weakness. The name is actually a misnomer because it is actually a clinical equivalent of the physiological stretch reflex. It is so called because the tendons are used as a facilitating structure to stretch the underlying muscle. And the reflex is actually done at the bedside to assess the status of the integrity of the reflex arc or just the functioning of the reflex arc. Reflex arc is a familiar diagram for us because we have gone through it as a physiology student. You can see that the diagram shows the reflex arc in light of the muscle which is being tested. So the arc actually starts from the stretch receptors of the muscle, and you can see the afferent neuron highlighted by the uh, green line, also indicated by the blue down facing arrow, which enters through the posterior root and into the gray matter of the spinal cord, where the synapse, a single synapse, occurs in this. You can see that inside the spinal cord as indicated by the yellow arrow, and then after the synapse it goes out as the efferent motor neuron indicated by the blue line and also by the upward facing red arrow, and it goes back to the muscle and it causes contraction of the muscle. So this reflex arc actually happens in response to the stretch produced to the muscle as a result of striking the knee hammer on the tendon. Now, the reflex arc is basically controlled or perhaps inhibited by the parapyramidal tract, tracts which come along with the pyramidal tract, but I think we can remember it as a pyramidal tract for keeping it simple. So when the pyramidal tract is damaged, so the inhibition is lost and therefore the individual develops hyperreflexia due to unchecked functioning of the reflex arc. On the other hand, when there is damage to any part of the reflex arc, it can be the afferent neuron, it can be there in the spinal cord close to the synapse, or it can be the efferent neuron, the reflex is lost, producing what is called a reflexia. In stages of acute spinal shock where the entire spinal cord, especially the motor tracts, are non functional, you do get a reflexia. So when you do it in the bedside, there are a few points you need to remember. First is to keep the limb in the correct position. So this position is in such a way that the muscle is partially stretched, because partially stretched muscle respond to a stretch reflex better than the muscle which is in any other position. So in the diagram which is shown there, it is for the triceps muscle. The position in which the triceps is fully stretched is complete flexion of the elbow. You just do a partial flexion at the elbow. So position in such a way to stretch the muscle partially. Second is to allow a full relaxation of the limb. So I would suggest to keep the limb in such a way that a complete relaxation happens. As the case here, the patient is comfortably leaving the limb over the trunk. You should remember to expose the muscle because you need to look at the contraction of the muscle. Then identify the tendon where you are going to actually strike with the knee hammer. Give a controlled strike on the tendon. You observe for two things. Observe for the muscle contraction and the movement of the joint. So depending on that, you grade the reflex. So this is the bedside principles you should remember, which is applicable for all deep tendon reflexes. You may also view individual tendon reflexes and clonus under the playlist nervous system. can see many other videos in different system in this channel.